السلام عليكم، مساء الخير وكل سنة وانتم طيبين. رمضان كريم وإن شاء الله ربنا يتقبل منا ومنكم صالح الأعمال يا رب، والعيد جاي إن شاء الله كل سنة وانتم طيبين. أهم حاجة في الأول I hope إن إحنا كلنا نكون staying home وsafe وhealthy، دي أهم حاجة at the beginning. طيب قبل ما نبتدي النهاردة I want to say إن إحنا on behalf of Abbott Nutrition Middle East to Africa Pakistan region, my name is Dr. Ahmed Amin. I'm the area medical director. On behalf of Abbott, I would like first of all to thank you for accepting our invitation, being with us tonight. Also, I would like to thank you and welcome you to this special event, because we do have tonight an important session, and on top of that, one of the most eminent academic Professor Gamal Samy. Before we start, I'll share with you a few slides. Abbott يعني الحقيقة إن إحنا I'm really proud and want to be one of Abbott employee، إن إحنا عندنا very active R&D أو research and development department across the globe، وده بيعمل لنا culture ان احنا بندور على الانفنشن والبريك-through innovations. So Abbott is a science-based innovation company, and that's why around the world we had more than 600 scientists with different expertise، سواء كانت molecular biology مش بس physician، also في الchemistry في الphysiology and so on. والeager دايما is to strive for new innovation. Having said that, Abbott Nutrition هي بس جزء من الأربع أجزاء اللي فيها Abbott in general. In addition للنيوتريشن عندنا pharmaceutical ميديكال ديفايسز والدياجنوستيك. ولما بنتكلم على الدياجنوستيك وبنقوم في الوقت الصعب اللي هو في الكوفيد 19، Abbott Research Department came up with 5 tests to detect الكوفيد 19. اتنين منهم لسه متوافق عليهم من ال FDA under the emergency usage last week. Okay, so right now في 5 تيست، 3 منهم molecular و2 منهم detecting الكوفيد based on the antibody. Talking about going back again لقصة النيوتريشن والفورمولا، السلايد دي بتشو الكيوموليتيف في كل الببليكيشن اللي حصلت على الهيومن ميلك اوليجوساكرايدز اللي هو يعتبر النيو انوفيشن في العالم الفورمولا ان جنرال. وزي ما انتم شايفين لو بصينا على سواء كان اللون الازرق الغامق او الاحمر، ده معناه ان الاستاديز دي كانت either fully sponsored او حتى partially sponsored by Abbott، ودول تقريبا بيكونتريبيوت حوالي 80% من كل الهيومن ميلك اوليجوساكرايدز ستاديز. وباي ذا واي ان شاء الله very soon في مصر اعتقد by August October the latest السيميلاك with the new HMO هنسميه سيميلاك جولد will be ان شاء الله launched في مصر. طيب if we go into I will take couple minutes only talking about malnutrition and then I will lead the stage for Dr. Gamal. Malnutrition effect globally it's well known in حوالي 45% من المورتاليتي في children under 5 years either directly or indirectly related to the undernutrition, which means that we can see around 3 million deaths a year because of the malnutrition. يعني it's a pity in up till now حوالي 750,000 because of the suboptimal breastfeeding. And I think the worst part of the story إن لما بنشوف إن حوالي half of them يعني حوالي 1.5 مليون من المورتاليتيز ديت could be avoided by simple يا إما vaccination أو حتى nutrition. Okay, so malnutrition is globally has a major effect. In the term of the outcome على الديزيز being an independent risk factor, okay, it causes higher mortality and morbidity. Reason behind it إن مش بس increase the rate of infection ولا wound healing أو delay it at least, but on top of that, if we look at it from economic or financial point of view, because of the malnutrition, 2/3 of the patient once they enter into the hospital بيبقوا already malnourished. ده بمعنى إن هو triple تقريبا length of the hospital stay in the في الادلت at least، واccordingly double to triple increase في الكوست بتاع الهيلث كير in general. So in conclusion, nutrition is important. It has a global effect on the growth, on the development, especially for the children. But I will leave you with this $1 million question اللي هو are we as a medical and physician healthcare professional in general, okay, do we have a good medical nutrition education? Is it sufficient really or not? Okay, I'll leave you with that question as an open one, and it's given me a pleasure in to introduce without further delay Professor Gamal Samy, well-known طبعا figure in Egypt and the whole Middle East. It was a pleasure always meeting him, and I had him several times, not only in Egypt but also all over the Gulf. Professor Gamal Samy, he's the professor of pediatric and neonatology at Ain Shams University. He's also the president of the Egyptian Society for Neonatal and Preterm Care. And this is a really brief biography because I can keep going for like 5-10 minutes, but I'll leave you with Professor Gamal. Please welcome Professor Gamal. The floor is yours. Thank you.
My pleasure. Give me Okay, this you can hear me now. You can hear me now.
تمام يا دكتور.
Okay. So first of all, I would like to discuss some important definitions. Premature baby is a baby below 37-week gestational age. We can classify the premature baby into 3 categories. Very preterm, below 32 weeks. Moderately preterm, from 32 to 34 weeks. Late preterm, from 34 to 36 weeks. As regarding the birth weight, there are low birth weight, below 2.5 kg, very low birth weight, below 1.5 kg, extremely low birth weight, below 1 kg. So there is some overlap between preterm and low birth weight. Not all preterm babies are low birth weight, and not all low birth weight babies are preterm. Among the low birth weight, 2/3 are preterm, while among the preterm, more than 43% are low birth weight. So we could come to conclusion that some preterm babies are not low birth weight. There is special considerations in the preterm infant. There is a biological immaturity, some medical complications. There are limited stores of fat, glycogen, calcium, phosphorus, iron, and fat-soluble vitamins. There are inadequate nutritional intakes, and factors lead to these inadequate nutritional intakes are metabolic instability, GI mucosal immaturity, inability to suck or swallow below 34 weeks, ventilatory compromise with feeding. Feeds are sometimes stopped because of intolerance or operations or some procedures. All of these lead to cumulative nutrient deficits. So, importance of nutrition in NICU. As we all know, nutrition played a major role in the ultimate well-being of the increasing number of preterm infants who survive. And it is becoming clear that early nutrition intervention can have long-term consequences. This is quoted from the American Academy of Pediatrics 2004. And after 5 to 10 days in NICU, outcomes mainly are based on nutrition. This means after the first 5 days to 10 days, we could deal with the respiratory problems, with septic problems. And after 10 days, mostly the outcome of our babies will mainly based on the nutritional status. And the goal of feeding preterm baby should be to approximate the rate of growth and composition of weight gain for a normal fetus of the same post-conceptional age, and to maintain normal concentrations of blood and tissue nutrients. We all know that the normal weight gain in utero in the last 3 months is nearly about 15 to 17 grams per kilo per day. And this is the goal. We should try to approximate what happens in utero. So the growth parameters of hospitalized preterm infants, mainly weight, we should have a daily increment with 15 grams per kilo per day, length, increment of 1 centimeter per week, head circumference 1 centimeter per week. So this slide is very important about the phases of nutritional support of preterm and low birth weight infants. We have 5 phases. Actually, phase 1, most of the babies in the NICU, especially the low birth weight and the very preterm, comprise of parenteral nutrition. Phase 2, parenteral nutrition and starting the trophic feeding, the gut priming. Phase 3, the transitional feeding. We increased the enteral feeding gradually. On the same time, we withdrew the parenteral feeding. Phase 4, the babies come to complete enteral feeding. And phase 5, this is the post-discharge feeding, which is the topic of my presentation today. As regards the energy, an intake of 120 to 130 kilocalorie per kilo per day should meet the energy requirement of most preterm and low birth weight infants, allowing growth rates similar to that occurring in utero. And if we compare the needs and the caloric intake of a term baby versus preterm infant, the term baby needs only 2.2 grams per kilo protein, and this gives about 108 kilocalories per kilo. While in preterm infant, the need of protein is higher. We need 3 to 3.5 grams per kilo, which give us around 120 kilocalories per kilo. And if we more explain the energy need of the preterm and the low birth weight baby, the requirement mainly 5 divisions: basal metabolic rate, which is about 40 kilocalories per kilo per day, physical activity 4+, specific dynamic action of food about 10%, thermoregulation variable according to the status of the baby, and the gross about 70 kilocalories. This means a total of 90 to 130. And this is to match in utero gross of about 15 grams per kilo per day. Before going into details of the post-discharge feeding, I want to explain rapidly some very important practical hints in preterm and low birth weight feeding while in NICU. We have 4 topics: trophic feeding, feeding advancement, gastric residual, and finally non-nutritive sucking. As regards the trophic feeding, I'd like to stress the importance of starting trophic feeding as early as we could. The other names of trophic feeding are early feeding, gut priming. This means infrequent, small feeding numbers with small amounts. This trophic feeding will provide and will produce marked increase in plasma gut hormones levels, resulting in prevention or decreasing the gut atrophy, and on the same time, do not increase the incidence of necrotizing enterocolitis. If we neglect starting enteral feeding for any reason, such as baby on ventilators, a baby with sepsis, we should start even very small amount, because if we don't, we have a problem. We have decreased intestinal size and weight. We'll have atrophy of intestinal mucosa. We'll have delayed maturation of intestinal enzymes with increasing intestinal permeability and bacterial translocation. We will have lack of hormonal response, such as gastrointestinal, and delay in maturation of intestinal motility and motor activity. As we see, there is huge benefits of starting trophic feeding. So trophic feeding start when? On first day of life or next day at the maximum. Why early? Because delay only will postpone maturation and will induce intestinal atrophy. And early starting will not increase the risk of necrotizing enterocolitis. And how to start trophic feeding? Priming with human milk is the preferred option if we have human milk. Why? Because human milk primes the gut more efficiently and more safety than anything else. And priming with very small amount, as we said, just 1 to 2 milliliter every 8 hours will be a good start. And when to start to increase the amount when residuals begin to decrease. And why is the human milk is so important for gut priming? Because human milk has strong trophic effects, strong anti-infectious effects, protects against sepsis, NEC, and death. So advantages of gastrointestinal priming, trophic feeding, shorten the time to regain birth weight, which is very important, improve feeding tolerance, the reduced duration of parenteral nutrition, enhance enzyme maturation, reduce intestinal permeability, improve GI motility, maturation of the hormonal response, improve mineral absorption and mineralization, reduce duration of phototherapy, and finally, decrease the incidence of cholestasis. And feeding advancement in very low birth weight infant Usually, we start feeding on day 1 or 2. We start with low volumes. We monitor the gastric residual, increase the amount slowly in frequency and or size as residual subside, and don't hold feeding because of occasional large residual, and pay attention to passage of meconium. This is very important. The gastric residual, I'd like to stress some important points. Gastric residual are normal in the first 2 weeks of life, sometimes green or yellow. This has nothing to do with necrotizing enterocolitis, consists mainly of gastric secretion, do not indicate intolerance, indicate immature motility mostly, and do not indicate NEC or impending NEC unless there is other signs are happening. Finally, the non-nutritive sucking. Sucking performs an important physiological role, inducing release of key regulatory hormones before food has entered the gut. Infants fed by tube feeding do not experience these physiological events. So using non-nutritive sucking by pacifier during a wash feeding in a small preterm infant accelerates the maturation of sucking reflex, facilitate transition to full enteral feeding, reduce the intestinal transient time, and result in more rapid weight gain. And actually, I saw this myself in one of the biggest NICU units in Miami, in the state. They give the pacifier to all the low birth weight baby to encourage starting sucking reflex. So from all of the above, I would like to stress that the preterm newborn is a case of nutritional emergency, because neonatal transition from anabolic to catabolic state, because of glucose stores is only around 200 kilocalories with IV glucose alone, the baby will lose 1% of his body protein every day, and 10% loss of protein stores will mean protein malnutrition. So most preterm infant leave the NICU with significant nutrition and growth deficit. Actually, optimal nutrition will prevent long-term problems with poor head and brain growth, slow weight gain, osteopenia of prematurity, anemia, ultimate short stature, and poor neurodevelopmental outcomes. At hospital discharge, low birth weight and preterm infant are often discharged from our hospitals weighing 1,800 to 2,000 grams, even though they may be less than 40 weeks post-conception age. And sometimes nowadays, I discharge some cases from my unit with only 1 kilo 600 grams for fear of nosocomial infection and to decrease the cost. They are going home with total body deficient of key nutrients, protein, fat, calcium, phosphorus, zinc, and possibly other nutrients. When the preterm infant leaves the hospital, his or her protein needs are still much higher than those of term infant. Also, the infant has almost always under-mineralized bones, so the infant needs more protein, more mineral than the plant mother's milk or term formula can provide. So finally, at hospital discharge, there are lower weight, lower body stores of nutrient, deficient bone mineralization, accumulated energy deficit, growth status is below that of a term infant of the same gestational age. All of these will lead to more morbidities. And standard term formula does not meet the discharged low birth weight and preterm infant estimated nutrient needs and typically consumed volumes. And preterm infants fed term formula have demonstrated retarded growth with problems in bone mineralization and in cognitive development, IQ. Sometimes in hospital, low birth weight and preterm infant are fed premature formula, which is higher in nutrients and more calorie dense to support growth. we should take care that some nutrient available at high level in the preterm formula might reach nearly toxic levels, considering the huge volume consumed by this preterm baby after discharge, mainly as vitamin A and D. So, feeding after hospital discharge, we have three choices: either breastfeeding, which is the best if it is available and in good amount. Some use, especially in the few years ago, a full-term formula, or nowadays the enriched formula, or what's called post-discharge formula. Why is the confusion? Actually, because there's different companies, different brand within the same line of production, evidence-based scientific support versus marketing tools, and safety issues. All of these lead to some confusion to doctors and parents. And always we faced with the question, what is the best formula for my baby? This is always the big headache we have. We compare here some items in the preterm formula versus the post-discharge formula versus the term formula. As regard the caloric value, the preterm formula gives about 80 kilocalories. The post-discharge mainly 72 to 74. The term formula 67. The protein in the term formula, as we see here, is 2.1. In the preterm formula, 3.5, as we said before. In the post-discharge formula, we speak about 2.8. Vitamin A in the term formula 300, while in the preterm formula 1,250, post-discharge formula is 460. This is why if you continue on preterm formula for a long time, we'll have vitamin A toxicity. And the calcium also is higher in preterm formula, nearly double in term formula, and the iron is the same in all the three formulas. So what are the advantages of the post-discharge formula? The other name in nutrient enriched feeding. There are increased protein intake, decreased volume intake, improved growth rate, and improved bone mineralization. Coming to a very important term, which is the catch-up growth, studies in preterm infants suggest that greater intakes of protein result in greater rate of weight gain and nitrogen retention, allowing for catch-up growth. Large, stable preterm babies may show catch-up growth in the first 1 to 2 years. Very low birth weight and extremely low birth weight infant may not catch up in the first 3 years. They might catch up to other normal children by up to 7 and 8 years. So we told the parent, if the baby is large, stable condition, he will catch up during the first 1 to 2 years. Don't worry if he had some delay in growth parameters, in developmental parameters. He will catch up completely within 1 to 2 years. But the very low birth weight, extremely low birth weight with 700 grams, they may not catch up completely in the first 1 to 3 years. It may even catch up to 7 and 8 years. We had a very interesting article in American Journal of Obstetrics and Gynecology, an old one in 1982. And this article was about the failure to catch up in weight by 8 months. And they found that it is associated with decreased head circumference, decreased Bayley's developmental score, increased rate of neurosensory impairment. And this is comparing the brain size, which is represents the head circumference between 31 and 40 weeks, and actually small head circumference may have particular prognostic significance for later neurodevelopmental assessment. So one of the most important prognostic factor, as we will see now, is measuring the head circumference. And increase the head circumference growth between birth and 1 year is usually associated with increased IQ. Coming to some published studies prove the efficacy of post-discharge formula. This old one from Pediatric Nutrition Handbook in 1998 from the Committee on Nutrition, American Academy of Pediatrics. They do randomized prospective trials of post-discharge fortified formula, and it showed significant improvement in growth and development IQ at the corrected age of 18 months when compared to standard formula for full-term infants. Another study by Carver in 2001, the article was about the growth of preterm infant fed nutrient enriched versus term after hospital discharge. It's published in Pediatrics, Journal of Pediatrics 2001. It was a double-blind randomized clinical trial, which means very high evidence-based rate. Aim of the study was to evaluate the growth of preterm infant fed post-discharge formula or a term formula for 1 year, 12 months corrected age. And the post-discharge formula used was Similac New Sure. And the result was gained more weight at 1, 2, and 6 months corrected age, greater body length at 3 and 6 months. This was more significant in infant with birth weight below 1,250 grams compared with the infant fed term formula. Those fed the nutrient enriched formula, post-discharge formula consumed less formula, more protein with similar caloric intake. Conclusion of that study, growth was improved in preterm infant fed the post-discharge formula versus the standard formula. And this was especially effective in infant weighing below 1,250 grams at birth. Another study of 𝐋𝐢𝐯𝐞 at et.al., published in Pediatric 2001, stated that infant-fed post-discharge formula with DHA had improved visual development at 6 months corrected age versus those fed the control formula. Also, there is improved language development at 14 months corrected age in subset of infant fed post-discharge formula with DHA compared of those fed the control formula. 𝐋𝐢𝐯𝐶 et al. Study 2010, published in Pediatric Research. It was the first longitudinal study to evaluate total and regional body composition in preterm infant during the first year of life. And this study suggests that more rapid and more complete catch-up growth in infant fed the nutrient-enriched formula to 6 months corrected age. Infant weighed more in this group, but percent of body fat was not changing at 3, 6, and 12 months corrected age. Infant growth was not associated with altered adiposity, but rather an increase in the lean body mass. This is published at 2010. Coming to some important and respected medical authority, we will see what they said about the post-discharge formula. The American Academy of Pediatrics in 1998 stated that with infant now leaving neonatal units at weight as low as 1,500 grams, re-evaluation of discharge formula prescription is needed. Preterm discharge formula should provide low birth weight and preterm infant nutrient intake that is between the preterm and term infant formula. This was at 1998. In 2004, the same American Academy of Pediatrics stated that the use of specialized preterm discharge formula to postnatal age of 9 months result in greater linear growth, weight gain, bone mineral content compared with use of term infant formula. The ESPGHAN recommendation 2004, early nutrition reduce the degree of growth failure and may limit the need for high nutrient supplies for preterm infant after discharge. Infant discharged with subnormal weight for post-conception age and thus with an increased risk of long-term growth failure if fed on human milk should be supplemented to provide an adequate nutrient intake. If such infants are fed formula, they should receive special post-discharge formula. Again, they should receive post-discharge formula with high content of protein, minerals, and trace elements, as well as L-CPUFA, at least until a post-conceptional age of 40 weeks, but possibly until about 52 weeks. In 2007, American Academy of Pediatrics and the American College of Obstetrics and Gynecology statement guidelines for perinatal care stated that the use of post-discharge formula has been shown to result in greater linear growth, weight gain, bone mineralization when compared with the use of term formula. In addition, small preterm infant may benefit from the use of such formula for up to 9 months after hospital discharge. Up to 9 months after hospital discharge. This is 2007. Coming to our conclusion, at hospital discharge, growth status below that of term infant of the same gestational age. We have lower body stores of nutrient, deficient bone mineralization, accumulated energy deficit. Growth measures for preterm infant remain lower than term-born infant. Low birth weight and preterm infant have greater nutrient needs. Feeding standard term formula may not meet their needs or allow catch-up growth. Consider human milk fortifier or supplementation with post-discharge formula. Supplementation multivitamins and iron until reaching 5 kilos at least. Monitor plasma phosphorus and alkaline phosphatase activity at 4 and 8 weeks after discharge. Early catch-up growth associated with better outcomes. Catch-up growth in head circumference may be particularly important. Post-discharge formula have been found to be safe. It seems reasonable not to use standard formula for post-hospital nutrition, especially in those born under 1,500 grams. Post-discharge formula need to be used in order to achieve maximum benefit. The effect of using post-discharge formula on linear growth persisted for at least 9 months beyond the period of dietary intervention. Very interesting information. What do you think the following notables have in common? Winston Churchill, Charles Darwin, Victor Hugo, Isaac Newton, Voltaire. The most important that all of these were born preterm. So, my friends, good nutrition does not only save lives, but more important, it saves brains. Finally, give early arrivals a strong start. And thanks for your attention.
Thank you, Dr. Gamal, for this interesting session. I think the time flew by and passed by, though we need more and more from you, to hear more and more from you. But I do have a quite big list of questions. So if you don't mind, I will start sharing the question to you one after the other.
Okay.
And the first one said, do you think that the birth weight or gestational age are more correlated with ultimate IQ outcome? It's from Dr. Hamid Al-Khayyat.
First of all, it's my honor to have Professor Hamid Al-Khayyat with us. Dr. Hamid, the birth weight and the low gestational age both are correlated with the ultimate IQ outcome, especially if we don't meet the nutrient deficits early. So if you have a low birth weight and with small gestational age, but you fed him properly, you give him post-discharge formula, you give him vitamins, iron, you will have a good outcome. But if you leave your baby, the preterm and the low birth weight without supplementation, definitely there will be affecting his IQ.
Okay. The second question, Dr. Gamal, from Dr. Osama Arafa, he's thanking you for the excellent presentation and asking if we prescribe a post-discharge formula, is there any need to add other trace elements or vitamin supplement to it.
First of all, thank you, Dr. Usama, our moderator for our webinars. Good job and good questions. At fact, yes, Dr. Usama, if we prescribe a post-discharge formula, there is no need to supplement the baby with other trace elements. May you need, if you have low hemoglobin, you may need supplement with iron and folic acid.
Okay. But the PDF or the post-discharge formula by itself, Dr. Gamal, is good enough for a
Yes.
normal preterm baby.
Yes, mostly alone doesn't need any supplementation.
Okay. Okay. Now, when should I start the post-discharge formula?
Immediately with discharge of the baby from your neonatal intensive care unit, and the baby is around more than 1,800 or 2 kilos, you can start the PDF.
Okay. This question, thank you, Dr. Gamal. This question from an anonymous attendee, but he's asking outpatient care or discharge follow-up long-term outcomes like obesity later on.
This is a very good question.
Yes.
The post-discharge formula definitely will decrease the possibility of having metabolic syndrome in infant of diabetic mothers. So will decrease not only the obesity, will decrease also the hypertension, the diabetes, all the metabolic syndromes. So we should start as early as the post-discharge formula to reduce the incidence of obesity later on.
This question, Dr. Gamal, I'm not sure of the name of the person, but it says Kona Bitingo, and she's asking, or he's asking, why is regular formula used initially to the preterms who are not full feds yet?
I will read the question again. Why is the regular formula used initially to preterm who are not fully fed yet, and then shift to preform one? Okay, dear Kwana, I think this from Nigeria, maybe. Yeah, because in the past there was no only formula available is the term formula. The revolution after the term formula, we have the preterm formula. So we started to use it in the neonatal intensive care unit. And lastly, we have the post-discharge formula. So we should use the preterm formula inside the hospital until your baby is coming slightly bigger and he is now ready for discharge. Then you discharge him with the post-discharge formula, not the full-term formula, not the preterm formula.
Professor Hamid is really active tonight, and he came back again with another nice question asking, what is the ideal time to shift from post-discharge formula or preterm formula to the full-term formula? So when to shift to the full-term?
Dr. Hamid also always have difficult questions. Dr. Hamid, we have two options to shift from PDF to the full-term formula on two occasions. Either you use the American Academy recommendation of up to 9 months, or you have another option when the baby catch up and now he is weight proportional to his peer corrected gestational age. This means either you can continue for 9 months, or you just shift to the term formula when the baby's weight is now similar to his weight if he is full-term baby after catch-up.
Dr. Gamal, may I interfere here and ask you, this is maybe a personal one, because this is what I'm seeing in the practice in most of the Gulf countries even, and despite all the information from the American Pediatric Academy, I'm seeing and I'm hearing this objection from many even native Egyptian physicians around us. They keep telling, I will never use a post-discharge formula for longer than 6 months. And maybe this is taking me to the next question from an anonymous attendee saying the hazard of high protein formula before discharge.
You see, all of these are right. You can use 6 months, it's okay. You can use 9 months at some recommendation of the American Academy. You can use until the weight becomes similar to the peer. You can use, you have the 3 options. And don't be afraid from the higher protein, the higher minerals, because it is not like present in the preterm formula. If you continue on preterm formula for a long time, definitely you will have some intoxication, especially vitamin A and D, because it's very high. As I told, vitamin A, it reached 1,205 unit, which is in the normal, and in the post-discharge formula is less than 200 only. So we don't advise continue on the preterm formula for a long time. Never to continue preterm formula more than 2.5 kilo, at maximum 2.75 gram.
Okay. And Dr. Manel Michael is asking if the post-discharge formula was not available for how long can we use the preterm formula in the preterm after the NICU, the NICU discharge?
Just answer this now, Dr. Manel.
Yes.
You can use the preterm formula up to 2.5 to 2.75 kilo, not more.
Well, Professor Hamid is coming back again, and he's focusing tonight. He's very active with us tonight, Dr. Gamal, and asking, do you think that the post-discharge formula may affect the kidney and cause some cardiovascular complication due to the high protein? I think you just answered this one. And this is part of the story that I've just mentioned, Dr. Gamal. This I heard it from many professors. Even they keep telling, after 6 months, I'm putting this baby or this infant prone to cardiovascular metabolic syndromes later on in life. But I guess you just mentioned like up to 9 months or even 12-month studies have shown that it's safe to be.
To show a point that all of us know that Formula 2 after 6 months in all brands having higher protein than in stage 1.
Yeah.
And so the protein in the Formula 2 usually is more than the protein in the post-discharge formula. So I don't have any fear about using the post-discharge formula up to 6 or even more. And all the safety studies showed no complication. If you use it properly, no kidney or cardiovascular complication.
Great. Dr. Hassan Muhammad is coming back with the same question. You just answered it, is to what age or weight should we give or use the preterm formula? I guess this is fine. I guess this is Bishu is asking post-discharge formula في السوق المصري.
Yes, post-discharge formula are available. I will lead Dr. Ahmed Amin to speak about it at the end with a good surprise for all of us.
Yes. Thank you,
Dr. Hayat asking again about what is the
the market, yes.
Few minutes, Professor Hamid, and we'll know. Dr. Muhammad Munsif.
Exactly.
My question: when to stop
the post-discharge formula and watch?
I just answered it. You can stop it whenever you have a good catch-up, or even up to 6 or even 9 months.
Dr. Khadija is asking, is the breastfeeding with multivitamin and iron supplement enough for post-discharge preterm feeding, even for developmental later on?
Dr. Khadija, we don't have any hesitation about breastfeeding. If you have a good amount of breastfeeding for a preterm or low birth weight after discharge, you can use it, and just the fortification or supplementation. But coming to the practice, actually, how much of your very low birth weight or very preterm babies staying at your neonatal unit for maybe 3 or 4 weeks will have breastfeeding reach in amount sufficient for compensating the deficit for this baby? It's very little. But if it's present, breastfeeding is number 1.
Great. Thank you, doctor. This is maybe not related to, he's asking, Dr. Ala is asking about the use of Similac Total Comfort.
This is not Dr. Ala today.
Exactly. We're giving preterm formula. Do we need to give extra iron?
After the session,
yes.
Muhammad Yassin about the MST oil using in NICU for feeding of premature baby. Medium chain triglyceride using in NICU is very important actually, for not just its nutritive value, but for the vision, for the brain, very important. So most of the preterm formula containing actually MCT. Hani, Dr. Hani, if we are giving preterm formula, do we need to give extra iron and vitamins? The answer is the same. If it is preterm formula, good one, you don't need to give an extra iron or vitamins. Dr. Ahmed, does the baby with post-discharge formula will require any lab work all over the time of supplement with formula during follow-up? Usually, Dr. Ahmed, we don't. But if you have some clinical signs, you may need to do some investigation. But usually, we don't need any investigation with using the PDF. Dr. Ahmed Amer, in breastfeeding in post-discharge, do we need to add any supplement rather than vitamin D3? It depends on the amount of breastfeeding and if it is breastfeeding alone or breastfeeding supplemented with artificial one. If breastfeeding alone, definitely you will need vitamin D. Vitamin D is given to all babies nowadays, just from the first day of life, if you could. And you may supplement with other mineral and trace elements. But if you use post-discharge formula, and in this case, I mean if breastfeed is not available or there is any complication or any contraindication to use it, you can use the post-discharge formula. It is supplemented with all the minerals and trace elements you need. Dr. Farida Mustafa, why follow up phosphorus and alkaline phosphatase? I understand point of vitamin D toxicity on preterm. So we sometimes need higher phosphorus because there is something called osteopenia of prematurity. And if we neglect giving the proper amount of calcium and phosphorus with the vitamin D, we will have a problem with osteopenia. It means like rickets in older infants. But vitamin A toxicity, yes, if we use the preterm formula for a long term, for a few months, especially after discharge, definitely you will reach a toxic level. Preterm with physiological anemia, you said we should give supplemental iron. Isn't milk formula fortified with iron? Yes, fortified milk formula having good amount of iron, but for only maintenance dose. If we have anemia of prematurity, if we have low hemoglobin and with low iron stored, low ferritin, you should give with the formula iron until you treat the anemia. Then the iron in the formula will justify only for maintenance, not for treating deficiency. Dr. Peter, how do we give post-discharge formula along with breast milk? This is a very good question. Dr. Peter, if you have breast milk, even small amount, I would like to encourage the mother to use it. But if it is not enough to give the baby the requirement he needs and caloric intake and to reach catch-up, we should supplement the breast milk with the post-discharge formula. This is a very important point. Dr. Dalia Shihata, what is supplement in Egyptian market and how can we add it to milk? This will be answered at the end, Dr. Dalia. If baby has cow milk allergy, what we can give preterm baby? If it is proven cow's milk allergy, there is no other choice to use the HA formula, and even we can reach to use the amino acid formula. These are the hypoallergenic formula that could be used. And nowadays, there will be HMOs in the market very near, so this will help a lot in these cases with cow's milk allergy. Breastfeed can post-discharge. دكتورة نوران محمود سؤال جميل. Breastfeeding can alternate post-discharge formula? Yes, very important. Because some mothers have a small amount of breastfeeding and would like to encourage to use the breastfeeding, but it's not enough. So we can use either alternating. This means one feeding breastfed The next is post-discharge formula, and so on. Or we can start every fed with breastfeeding and supplement or complement with the post-discharge in the same feed. Dr. Muhammad Mahmoud, for how long we use PDF, we answered before. Doctor, nice presentation. Iron deficiency anemia lead to irreversible brain damage. Can we add iron supplementation early in preterm or term infant even with normal iron level? This is very good point. Yes, iron deficiency anemia, especially the severe one, will lead to irreversible, not brain damage actually, it is irreversible cognitive affection, and it will not be corrected even if we give iron later on. So we should supplement iron to all babies with breastfed starting from 6 months. And that's why nowadays in the office, in the health office, the governmental health office, they do hemoglobin level at 1 year as a screening tool for iron deficiency anemia. And if there is iron deficiency, we should start giving iron, not depending on the iron present in the formula. Dr. Farida, what is normal gain of head circumference in first year? We speak about the low birth weight baby with 1 centimeter every week during the hospital stay. After that, it is nearly the normal rate of the full-term babies. Just the very important increase in the head circumference is associated with the IQ. So please, the most important and most correlated prognostic factor with the IQ is the head circumference. Dr. Ahmed Omar, when we use high energy formula and it's allowed in preterm baby, yes, it's allowed, of course. It is a post-discharge formula for preterm and low birth weight, but usually we use it after discharge. While the baby, the low birth weight and the preterm is in the NICU, we use the preterm formula. The baby coming well, stable condition, reaches a good weight, then when discharged, we shift it to post-discharge formula. Dr. Amira Shalabi, do we start trophic feeding for preterm by human milk or full-term formula instead of low-caloric preterm formula, which is not available? Dr. Amira, we should start the trophic feeding with the milk, whatever the type is available. The priority, of course, to the human milk. If there is no human milk, we use the preterm formula. And nowadays, especially in Egypt, we have 3 preterm formula available in the units. And if you don't have it, we just advise to have half concentration full-term formula. Dr. Irini, is breastfeeding used with post-discharge? We answer it again. I don't know if we can have some time more, Dr. Ahmed. Continue.
If we can go for ask for like 5 more minutes. So we take a few more questions, 3 more questions, Dr. Gamal, if you don't mind.
Okay, Dr. Adel Riyad, I am so upset I couldn't join the webinar. There is I have some technical problems. Dr. Muhammad Shihab, is there a determined weight or decision age to start PDF formula? Is it for late preterm, for example? A good point. Dr. Muhammad, you use the post-discharge formula whenever the baby discharges from your unit, or at most when the baby reaches 2.5 kilos, you shift to the PDF from the preterm formula. And it is very suitable to late preterm. If you asked about this point, it's very suitable. Dr. Ihab Khairi, thank you for this excellent presentation. Do you think high protein in post-discharge formula can lead to programming towards obesity? Dr. Ihab, طبعا يعني head of nutritional unit, very good question. I just give point about that. Dr. Ihab, if you continue the post-discharge formula up to 6 months, no problem at all. If you continue more than 6 months, you will have the protein less than the protein found in the stage 2 formula. So, يعني, there is no risk for having obesity if you use it and stop it when we reach the catch-up weight gain. So it needs just wise use. But usually, if you use it properly, you don't have to be worried about programming with obesity. And this is actually, Dr. Ihab, from our practice. We use the post-discharge formula. It is not a new formula. It is used in the Egyptian market for many, many years now. And in the Gulf for more than maybe 20 years, Dr. Ahmed, for a long time.
Yeah.
Dr. Mohammed Samir, what's the difference between different preterm formula? How we choose the best formula? The preterm formula, just I said we have 3 formula, all of them giving the same range of caloric intake between 74 to 80. There is difference in the protein content, in the mineral content, but all of them are suitable to be used in the neonatal units. Dr. Safa, what is the difference between preterm formula and how we choose it? I make a table, the difference between the preterm formula and post-discharge formula. It is the post-discharge is little in the protein content, little in the vitamin A and D content, less in calcium and phosphorus than the preterm formula. That's why we cannot continue in preterm formula for months. Just it is a transitional period from the delivery until the baby is okay, delivered, going home, you shift to the post-discharge formula, especially if you reach 2.5 or 2.7 kilos.
Dr. Gamal, let's take one more question. This will be the last one.
Dr. Iman El-Bahiri, thanks so much. Excellent presentation. Helping us. Just want to ask about use of probiotics. Dr. Iman, this is a very large topic. I will be happy to answer you after the session. You can call me at any time. Thank you, Dr. Ahmed. It was very interesting and very interactive session.
And on behalf of all of the attendees and on behalf of Abbott Nutrition, I would like to thank you a lot for this very interesting, exciting presentation. We really benefit a lot out of it. I know there are many other questions. I will try to manage with my colleagues in Egypt, also in Abbott Nutrition Egypt, together all the rest of the questions. Maybe we can be able to get the answers from your side, and then if we can add them together and send them to everyone. So on behalf of everyone, I'd like to thank you.
It will be my pleasure, Dr. Ahmed, to answer all of these inquiries.
Thanks a lot. I'm sure you can. You'll. For all the attendees, thank you very much for this interactive session. It was really great. And before we go, I do have a surprise from Abbott Egypt that I would like to share with all of you. And the reason I said so is Abbott, in part of our responsibility towards the society and the community where we're living. And we decided, because of the COVID-19 situation, and we know how critical it is, so we slashed the prices. قررنا ان احنا ننزل اسعار السيميلاك بكل الجريدز بتاعته ستيج 1 و 2 و 3 من 99 جنيه، وحاليا هيبقى موجود في الماركت افكتيف بكره ان شاء الله هتلاقوه ب 75 جنيه بس. سو اما بالنسبه للبوست ديسشارج فورمولا اللي هي السيميلاك نيوشور يا دكتور حامد، it is available in the market. So with this last statement, I would like to thank you all. Have a good one. وإن شاء الله كل سنة وانتم طيبين، العيد جاي، وhopefully نتقابل physically face to face بعد البانديميك بتاعت الكوفيد دي will disappear soon إن شاء الله. So till that time, take care of yourself, stay safe and healthy. With best of luck. Thank you.
Thank you.